Understanding Attention Deficit Hyperactivity Disorder by Dr. Sana Yunus, Child Psychiatry Edition Soul. ADHD or Attention Deficit Hyperactivity Disorder is one of the most commonly diagnosed neurodevelopmental disorders worldwide. Over the past century, research has greatly improved our understanding of neurobiological mechanisms that govern focus, concentration, and executive functions. These advancements are reflected in the evolving diagnostic criteria, which now encompass various subtypes of ADHD. What was once viewed as a moral failing, described as defective moral control by a British pediatrician in 1902, and later termed hyperkinetic impulse disorder in 1960s, is now recognized as a chronic neurodevelopmental condition. ADHD parents with symptoms of ADHD presents with symptoms of hyperactivity, impulsivity, inattention in childhood, often continuing into adulthood. In 1960s, when diagnostic criteria were narrower and focused primarily on hyperactive subtype, ADHD prevalence was estimated around 1 to 2%. By 1990s, with the introduction of ADHD subtypes in DSM-4, prevalence increased to 3 to 5%. Current estimates suggest a global prevalence of around 5 to 7% with significant geographic variation. In diagnosis rates, raising important questions about both overdiagnosis and underdiagnosis. For instance, could normal childhood behaviors be misinterpreted as ADHD in environments with high academic expectations? Conversely, is ADHD underdiagnosed in contexts with where academic performance is less rigorously monitored, or where mental health stigma, gender stereotypes, and limited resources hinder the identification of neurodevelopmental disorders? These questions are as relevant in Pakistan as anywhere else, underscoring the need for comprehensive assessments, accurate diagnosis, and evidence-based management of ADHD in children and adolescents. Risk factors of ADHD include the exact etiology remains unclear, but research has identified several risk factors. Prenatal exposure to alcohol and tobacco, low birth weight, prematurity increases the likelihood of developing ADHD. Socioeconomic stressors and environmental toxins may also contribute. ADHD is primarily associated with dysfunction in brain's dopaminergic and noradrenergic systems, particularly in regions governing executive function, attention, and impulse control. Key brain areas implicated in ADHD include prefrontal cortex, responsible for attention regulation and behavioral control, and basal ganglia, which is involved in motor activity and impulse regulation. Neuroimaging studies reveal reduced activity and structural differences in these regions. Abnormal dopamine and norepinephrine transmission disrupts neuronal communication, leading to core ADHD symptoms. ADHD also has a strong genetic component with a heritability rate of 70 to 80%. In clinical settings, it is crucial to assess whether parents or siblings have ADHD, their treatment experiences, and outcomes of these treatments, as this information can guide management plans and improve therapeutic alliances. Clinical presentation of ADHD is characterized by persistent patterns of inattention, hyperactivity, impulsivity that are appropriate for child's developmental stage. The clinical presentation varies by age. Preschool and early school age children may display excessive motor activity, fidgeting, difficulty sitting still, whereas teenagers often present with inattention, impulsivity, and executive dysfunction. Common concerns include poor academic performance, difficulty focusing, and time management challenges. While ADHD symptoms typically begin before 12 years of age, many children and adolescents continue to experience these symptoms into adulthood. Gender differences are notable, with girls often presenting with inattentive symptoms and boys more frequently showing hyperactivity and impulsivity. Diagnosis is based on DSM-5 criteria and is primarily clinical, though comprehensive psychiatric assessments are essential. These assessments should include a thorough review of psychiatric, neurological, and other relevant symptoms. Consideration of differential diagnosis and analysis of psychosocial factors. Input from schools, including psychometric tools like the Vanderbilt ADHD Diagnostic Rating Scale and academic performance reports, is vital in determining the degree of functional impairment. Medical, developmental, social, and family histories are also crucial components of assessment process. ADHD treatment, pharmacological interventions. Number one, stimulants remain the most widely prescribed and effective treatment for ADHD, with response rate between 70 to 80%. These include methylphenidate, with an effect size of approximately 0.9. Methylphenidate significantly improves focus, attention, and impulse control by increasing dopamine and norepinephrine levels. Number two, amphetamines, which have a similar effect size 0.8 to 0.9, work by both blocking dopamine reuptake and releasing dopamine. Side effects including appetite suppression and irritability are common but manageable. Non-stimulant medications are generally second line. Atomoxetine, a selective norepinephrine reuptake inhibitor with an effect size of 0.6 to 0.7, atomoxetine is useful for patients who do not tolerate stimulants. Guanfacine and clonidine. These alpha-2 agonists are used for hyperactivity and impulsivity with modest effect size of 0.5 to 0.6. Psychotherapeutic interventions, including behavioral therapy, is effective in younger children. Behavioral therapy reinforces positive behaviors. However, its effect size 0.3 to 4 is lower than that of medications. CBT is useful for adolescents and adults, helping with reorganization, time management, and impulse control, with an effect size of 0.4 to 0.6. There are some emerging technologies. Endeavor treatment is first FDA-approved video game-based digital therapeutic intervention designed to treat ADHD in children between ages of 8 to 12. It works by engaging brain's attention systems through challenging tasks and adaptive gameplay. The studies have shown modest improvements in attention with an effect size of around 0.4. While it is not a replacement for traditional treatments, Endeavor treatment provides a novel adjunctive therapy for managing ADHD symptoms. TNS, that is trigeminal nerve stimulation, is a non-invasive treatment recently approved for ADHD in children aged 7 to 12. It involves a small device that stimulates trigeminal nerve during sleep, thought to modulate brain activity related to attention and behavior regulation. Initial studies have shown improvements in ADHD symptoms with an effect size of 0.5, comparable to some non-stimulant medications. While still relatively new, TNS shows promise as an alternative treatment option, particularly for children who do not respond or tolerate medications. Detailed assessment, accurate diagnosis, and recommendation of evidence-based treatment of children and adolescents with ADHD by a knowledgeable healthcare professionals is a thorough process which requires in-depth understanding of subject matter and necessary skills and expertise in working with children, adolescents, their parents, and family members, in coordinating care with other healthcare and school professionals. This thorough process, when available, is based on the assumption that a child or adolescent displaying concerning symptoms has been identified and referred to such a knowledgeable healthcare professional who then makes a recommendation which is accepted and acknowledged by the family and is available and accessible to family. Various barriers at these steps impact early identification and overall prognosis of children and adolescents with ADHD. In situations where resources may be limited and mental health stigma may be pervasive, addressing these can be as important as performing a thorough assessment. A child who does not go to school or has a teacher who has limited understanding of ADHD or has parents or teachers who believe that some boys are hyperactive or disinterested in learning or believe that it is okay for girls to not get good grades in school may not be identified and referred for assessment despite having significant symptoms. A parent who does not think mental health disorders are real conditions or having a diagnosis means their child is weak or crazy may not bring their child for assessment, even if a school raised concern for either academic or behavioral issues. addressing myths associated with mental health disorders, clarifying and addressing preconceived ideas about diagnosis and treatment of ADHD with patients and families is a vital component of psychoeducation during assessment and overall improvement in mental health literacy of a community. In countries like Pakistan, limited availability and accessibility of evidence-based treatment interventions has a significant impact on overall prognosis. An alarming example of such a scarcity of resources is the limited availability of stimulant medications, which are the first-line treatment of ADHD. Of all the different stimulant medications, more than 20 formulations are available in United States, for instance, and approved by FDA for ADHD in children and adolescents. Only one of them is available in Pakistan. Limited training of pediatricians, general practitioners, and teachers in child and adolescent mental health disorders is another such example. These barriers highlight the areas where resources are needed, which can then have a positive impact on prognosis of ADHD and other mental health disorders in children and adolescents. Thank you for listening.